Hello and welcome. I'm Karen Carpinteris, Associate State Director for AERP here in Michigan. And I want to welcome you to tonight's presentation on back pain. So today's pain in the back presentation, we're looking at it from two different aspects. One from a physical therapy aspect on what to do, what to look for, and what can be possibly solved by physical therapy. And then if physical therapy doesn't fix the issue, what are the surgical options and what's involved in those surgical options? Unfortunately, so many of us are plagued by back pain, myself included. So I'm very much looking forward to today's presentation. So you can feel free to ask questions at any time during the presentation. We will answer them at the end, but you can put your questions in the comment section out there on YouTube and Facebook, and we will look for those and ask those live at the end. So go ahead and put those in the comment section. I would like to bring our first presenter on the screen, Jill Marlan. Graduated from Wayne State University with her master's in physical therapy. She continued her education at Michigan State University, where she completed the Osteopath Continuing Education Program, followed by Oakland University's postdoctoral orthopedic manual physical therapy program. Jill has taught at Oakland University and Michigan State University and has co-authored the Transthoracic Spinal Manipulation textbook that is used in the postdoctoral programs around the country. Appointed by two different governors, Jill sat on the State Board of Physical Therapy for 8 years, and she chaired it for 3. She collaborated in drafting the current rules that PTs, that's physical therapists, practice in the state of Michigan. As a college athlete, Jill had her fair share of back problems leading up to her own spinal surgery. With her knowledge, education, and peer assistance, she was able to walk down the aisle and dance at her wedding just 2 weeks after spinal surgery, and has led an active, pain-free life for over 18 years. So I want to welcome Jill to the screen. There she is. Welcome, Jill.
Thank you.
I'm looking forward to today's presentation, and I know we have a lot that's going to be presented today, so I'm going to go ahead and let you go.
Perfect. Well, thank you so much, Karen. I really appreciate it. And welcome, everybody, to our back pain presentation. Very excited to be here with each of you today. So we're going to talk a little bit about, a comprehensive understanding of low back pain today. And what I found is the more you know, the more educated you are, the better you are, and the more equipped you are to be able to handle these symptoms. So what we're going to be doing today is educating you, and then we're going to be transitioning you to Dr. Dorenkamp, who is a spinal surgeon, who will be able to kind of what next and what are the next steps. So just from a disclosure standpoint, in this presentation, so no specific disclosures that I have. And we're going to move on and talk about some of the objectives. So today, my hopes is that you're understanding some of the common statistics surrounding low back pain. You'll learn some of the most common causes of low back pain and a little bit about them. Understand your options if you do have back pain and ways to relieve your back pain. So moving in, I want to get a pulse a little bit right now on who's on the call or who's on the meeting with us so that I can curtail this a little bit more towards our audience. So we have a poll here that the poll is basically, have you experienced low back pain or pain that radiates down your leg? So yes, if you have, no, if you haven't. So I'd like to hear from you guys on, have you had low back pain at some point in your life that maybe has caused you to curtail your activities, something that's been achy or cramping in your leg, any kind of symptoms that you may potentially be having low back pain? So if yes, click the thumbs up button. If no, click the thumbs down button on that. So as we move on with that, and I will fill you in on the poll results a little bit as we move on, but I want to talk to you a little bit about the facts. So if you clicked yes, you are definitely not alone. Over 65 million Americans report a recent episode of back pain. 80% of all adults have experienced back pain, and as a result are limited in their certain activities of daily living or are curtailing what they have done. And back pain is the third most common reason to visit the doctor. So we know there is a tremendous amount of people that are suffering with this. 40% of adults say that back pain has affected their ability to get a good night's sleep. And we know that 85% of those people are sleeping less than 5 hours, which, if you're getting less than 5 hours of sleep due to low back pain, it's equivalent of drinking 3 beers. So you're almost in a state of drunken stupor a little bit if you're not sleeping because of your pain. So looking at the poll results, 85% of you have checked yes, that you have had some sort of back pain at one point or another. So you're right around with that 80% of adults. So you're definitely not alone, and you've come to the right place because we have some phenomenal information. So 60% of people with low back pain are prescribed opiates. And we know with the opiate pandemic that although oftentimes we hear opiates as, thinking of, street drugs and different type of narcotics, that many of people that are prescribed opiates and become addicted to opiates are because of some sort of pain incident or chronic pain that they've been dealing with. And so been prescribed these medications from their physician and then in turn get addicted. So 1 in 4 patients receiving long-term opiate therapy in a primary care setting struggle with opiate addiction. So us being able to be knowledgeable on low back pain, to have the information that we need, and to have the resources and the tools in our box to be able to treat and kind of move on from this chronic low back pain or low back pain at all is extremely important for our families, for our society, and across the board. So we're going to talk about today what are the top causes of low back pain. So causes of low back pain can be a herniated disc, degenerative disc disease, muscle strain, and sciatica. So looking at that, those are some of the 4 top causes. Now, there's obviously many other causes of low back pain, but these are the main causes that we see on a regular basis of low back pain. So let's talk a little bit about a herniated disc. And so I've heard anything from people coming in saying, I have a slip disc, I threw my back out, I've thrown something out, or I've torn a muscle, or I've torn a ligament. Everybody has their own terminology. So it's important that you understand a little bit of the anatomy. And so I'm going to talk about the anatomy where hopefully you have a better understanding of the terminology as we move through. So your disc is a pad that sits between 2 bones. And your disc is made up of 2 different types of structures. So on the outside, it's more ligamentous, and on the inside, it's more gelatinous. So you can think of that as more of like a jelly donut. And on the outside part, it's a little bit more thick and tough, and that is called your annulus. So the outer rim is called your annulus. On the inside is called your nucleus pulposa of your disc, and that's where it's a little bit more fluidy. Now, as you age, you start to lose that fluid material. So you see in the picture here of the herniated disc where it shows compressed spinal nerve and herniated disc there. So you see the outer portion of that rim has actually torn, and some of that fluid has moved out. Now, when that fluid moves out of the annulus or out of that rim of your disc, what happens is your body thinks of that as a foreign subject. So there's a tremendous amount of inflammation that happens and some irritation. And you see how the disc, or how that, the inner part of that disc is protruded out onto the nerve, and the nerve is red. The nerve actually gets red and irritated, and we call it a hot nerve. So when you have that rupture of your annulus, that material flows out that herniation occurs, and you can cause nerve irritation, which you can get irritation down your leg, you can get irritation that refers across your back or in the distribution that that nerve innervates down into your leg. Now, you can also get discogenic pain from a herniated disc if you have that tear. Now, once a disc has completely torn open, like you see here, and that's not quite as prevalent in the older ages. A disc herniation, an acute disc herniation, is much more prevalent in the younger ages, your 20s, 30s, early 40s, because you still have a lot of fluid in there. So when you tear, there's a lot of fluid to ooze out. As you age, you lose the fluid in your disc, and you're less likely to actually get a herniation. You're more likely to start to get fissures and little cracks in your disc and more degenerative changes. So understanding that is extremely important as we progress through this of what could be your cause. Now, when we're looking at a herniated disc, and so I talked to you a little bit about your disc is a ligamentous material that's between two bones. Now, a ligament between two bones usually and is supposed to provide stability. Your back provides a tremendous amount of stability of downward pressure. What your disc is not made for is for a tremendous amount of twisting and rotation, especially if you're bending forward and rotating. Because of the anatomical makeup of your annulus, that outer rim, it's at about 120 degrees of each other across. You have these little fibers that are attached that make up that ligamentous tissue. And when you bend forward and rotate, they line up and allows for that to move. Now, because it's more of a ligament, think about the ligament structures in your knee. It provides your knee from slipping back and forth. Same thing with your disc. It should be providing some good stability from your spine slipping forward and backwards and touching and irritating that nerve in there. So herniated discs, when you have a herniated disc, you then have a little tear in your ligament, which destabilizes your back a little bit. So that's extremely important to make sure that you counteract that with increased muscle strengthening in your low back. So moving on to muscle strain. So I'll tell you that a muscle strain or a muscle tear, so kind of stretching or tearing of a muscle or a tissue connecting the muscle to the bone in your back. So strains can often tear in your low back, in the muscles of the back, kind of that, those, where you can see that muscle goes in and then you have some of that fascia, that white is fascia, where your muscle comes in and attaches. When you have a muscle tear, you oftentimes will get bruising. You will have pain and irritation, so muscle spasm, limited ability to move. Now, I would say, though, that we oftentimes see a tremendous amount of people that come to see us that have been told that they have a muscle strain, when in fact they've had some sort of disc pathology. So typically, if you have a muscle strain or a muscle tear, you will actually have swelling and bruising directly over that site. If you have disc pain, then oftentimes you are going to spasm, because it's like you sprain your ankle. So your muscles are going to spasm, they are going to be sore, they're going to hurt, but the main cause is not necessarily a muscle strain. So oftentimes what we see is that individuals will go into the emergency room with an acute tear in their annulus, the outer donut part of the outer rim of your disc. Your muscles will be in spasm. You'll have tremendous restrained ability to be able to move, to bend, like you could not put your shoes and socks on if you've been there. Most likely that is an annular tear or a tear of that outer portion of your disc. So they'll go into the doctors and the doctors will give them some sort of potential anti-inflammatory, a muscle relaxer, and send them home. So an anti-inflammatory or some sort of pain reliever and a muscle relaxer. Now, if you have an acute tear in your back, you don't necessarily need a muscle relaxer right away because your muscles are doing what they need to do to protect your back. It's better at that time to actually provide some stability, similar to like if you sprained your ankle. So same structures, ligaments, tendons, bones, And so we want to make sure that we're taking the myth out of low back pain, because your discal joints in your back are very similar to some of your other synovial joints in your body. So if you have a sprain or a strain to the ligaments or the muscles in your back, you would treat it very similar to how you would your ankle. You're going to provide some good stability, some anti-inflammatories. You're going to rest, and we'll talk a little bit about important rest and what that looks like. But with a muscle strain, we have to be careful that you are diagnosing appropriately and that it's not a pathology of your disc. So that leads us to degenerative disc disease. So degenerative disc disease refers to symptoms of your back or neck caused by wear and tear of your spinal disc. So in some cases, degenerative disc disease also causes weakness, numbness, hot shooting pain into your arms or legs, which we call radicular pain. But degenerative disc disease typically consists of low-level chronic pain with intermittent severe episodes. So if you see the picture over here of your disc, so I showed you earlier the picture of the herniated disc where you have kind of an acute tear and all the fluid goes out. Well, how is that different from degenerative disc disease? Degenerative disc disease is when, with age, you start to lose the fluid in your disc. So you can see here on the disc that's a little bit more white in that picture, that you've lost the space or you've lost the height of your disc. And that's why people say, well, I've gotten shorter with age, or I used to be, 5'10", but now I'm actually 5'8". With degenerative disc disease, you lose the fluid and you do lose the height in your disc, which is the overall height of your spinal vertebral column. So with disc disease, we talked a little bit about fissuring. We talked a little bit about breakdown of that annulus, losing that height in through there. And as your disc starts to break down and not be so taut, you'll start to get increased movement or increased slippage of your vertebra. And as you have increased slippage of your vertebra, what happens is your body attempts to adapt. And so you'll start to get bony changes on the end plate or the end of your vertebra. So you see here, it's vertebra, disc, vertebra. And when you start to move and you start to slip back and forth, what happens is your body wants to stabilize that movement. And so it starts to, there's a thing called Wolff's Law. So as you stimulate a pull on a bone, you're going to get more bone. So that's exactly why they tell you as you age to make sure that you're doing weight-bearing exercises. As you're weight-bearing through your bones, you get more bone. In this case, as you're pulling on your bone and you're slipping, your bone's going to try to develop a bigger platform so that you're more stable. And hence, you're going to start to get what's called a traction spur or oftentimes a claw spur. So if with degenerative disc disease and you start to get traction spurs and claw spurs, those are typical signs that we read on MRIs of a history of increased mobility of the spine. So we assess joint play of your spine, but we also look very closely to make sure at any images to make sure that you don't have a history of increased movement. Now, oftentimes when you have an increased degenerative disc disease and as a younger age, you'll start to get that increased movement. As you start to age, what degenerative disc disease feels like to us when I'm actually feeling the motion of your spine is it starts to become really stiff. So you start to develop that bony lay down, you start to develop stiffening of your ligamentous tissue, increased stiffening of your fascia. So in your 30s, 20s, 30s, 40s, you're going to have potential tearing and fissuring, which is going to cause increased play. When you start to get in 50s, 60s, 70s, 80s, you're going to see that that starts to feel more stiff with decreased mobility, increased spurring, and lower spaces or smaller spaces of your disc in through there. And then we'll talk a little bit about sciatica. So I've heard anybody, from all of the different terms of sciatica, pain in the butt to a knife in my butt to radiating down my leg. Sciatica is a terminology that many people talk about and many people utilize. And what is sciatica? So sciatica refers pain that refers from your back because of an impingement of your sciatic nerve. So your sciatic nerve is one of the biggest nerves in your body. It's about the size of your thickness of your thumb. It's a very large nerve. It's made up of 5 different segments that come out of your back that come into one nerve. It runs down the back of your leg. It comes behind your knee, and then it splits as it comes down behind your knee. And so your sciatic nerve can cause inflammation, it can cause numbness, it can cause foot drop, it can cause weakness into your lower extremity, it can cause tremendous pain if you have irritation of your sciatic nerve. Now, oftentimes, the true definition of sciatic nerve is pain that refers from your back all the way down your whole leg. Now, I can tell you in physical therapy that with some of the manual skill sets that we have in evaluations is that we can evaluate so that individuals have come into us and have had pain in their calf and from their calf and into their heel and said, I've been told that it's not necessarily sciatica because it's not going down my full leg. Well, your nerves are really tricky objects and oftentimes can mislead you. These individuals, I had treated a professional golfer that had pain in his calf and into his heel. And he had been all around the country trying to get treatment. He had orthotics, he had tried different shoes, he had tried all the things, and he couldn't walk on tour because it hurt so bad in his calf and his heel. When we evaluated him, we were able to bring his pain on and take it away between L5 and S1 in his lumbar spine. So the pain that he was getting, it was because of an impingement of the S1 branch of his sciatic nerve. We went in and treated his back, and within 6 weeks, he was back on tour. And so I'll tell you, from sciatica, the true definition is all the way down your leg. But you can have impingement in your back, and that can be coming from your back, in which you're just getting symptoms maybe on the back of your leg or the side of your calf or just into your foot or just into your heel. And so it can be very tricky and sometimes deceiving, but oftentimes can be very treatable. So let's talk about ways, now that we know a little bit more about the anatomy. So we've talked about, what a herniated disc is, degenerative disc disease, sciatica, and, kind of a herniated disc type of things and muscle strains. Now let's talk about ways to maintain a healthy back. So there's 4 different pillars that we look at to maintain a healthy back. And oftentimes, if you talk to somebody, the first thing they'll say is, yep, I need a strong core. That's the first thing that anybody says is, with back pain, what needs to happen? I need a strong core. And they think about doing sit-ups. How many sit-ups do I need to do for my back to be strong? Well, if you think about that, doing sit-ups strengthens your abdominal muscles, and your abdominal muscles do not attach directly to your vertebral column. Now, through your fascial planes and through attachments through your pelvis, yes, they do, and they are definitely a counter on the front of your abdomen. But what is really important is that you maintain your strength of the muscles that attach directly to your spine. So you have paraspinal muscles that come down, you have these little tiny muscles that attach across, 2 to 4 segments called your multifidus muscle, your long paraspinal muscles, all that attach to your spine. It is important that, number 1, you maintain the strength of those. And number 2, you maintain good flexibility. So you maintain good muscle length. Your hip flexors, from a flexibility standpoint, so your hip flexors on the front of your hip, they attach deep into your groin onto the front of your femur, your thigh bone, and they attach on the front of your lumbar spine. And so if your hip flexors are tight, they can pull your spine forward to an increase what we call lordosis, or that sway back standing. As you increase that sway back, it closes the space on your back for your nerve root to come out, and it causes the narrowing of that space a little bit. So maintaining flexibility of your lower extremities, your core muscles, flexibility of your spine, and assuring that you're strong from a strengthening perspective of the right muscles, not just doing sit-ups. So good core stabilization is extremely important. And then nutrition. So the best foods to help with low back pain and decreasing inflammation are those that are high in antioxidants. So your lean proteins, unsaturated fats, foods that have these qualities are often, if you've heard of like a Mediterranean diet, they compromise plenty of fish, raw vegetables, fruits, whole grains, olive oils, those type of things that are very good, low inflammation type of diets. And then conservative care. So use conservative treatments first and avoid opiates if you can. Now there's going to be circumstance that you may need them. And I understand that the pain of low back pain is tremendous. However, long-term opioid use does not show to increase function and overall increase the overall mobility. So we'll move on to what conservative care looks like. So from physical therapy, how does that look? Or for those of you that have had physical therapy that have said, I've tried physical therapy, but it really didn't help. Let's take a look at that. There are different forms of physical therapy. There are physical therapists that are trained in manual therapy, and that's extremely important when you're in low back or have low back pain. You want to make sure that you go to a physical therapist that uses differential diagnosis. So I could tell you if you came in to see me, we would evaluate you, do a very thorough evaluation. I would be able to tell you if your pain is coming from nerve referral, from disc pathology, is it coming from a strained muscle? And if your nerve was getting impinged from your disc, I would be able to tell you what level based on specific tests and measures that we do. So you would be able to come in and say, Jill, I'm having pain in my back. It goes into my butt, down the back of my leg, into my calf, and into my heel. And it hurts so bad when I do this, this, and this. I would be able to, and what you would be able to, or you should expect from your physical therapist, is that when you leave, they would say, okay, your pain is coming from an irritation of your disc. It's affecting your S1 nerve root. It's affecting the strength of your hamstrings down into your calf muscle. You have weakness in your calf muscle, and you have changes in your Achilles reflex, which are all S1 nerves, right? And then you come forward with a specific hands-on approach for your case, because that same symptom could be related to a piriformis syndrome or something totally different. It could be coming from an impingement of your nerve in your hamstring. Say if somebody say does hurdles or something like that, right? So same symptoms, totally different cause. And if you're not treating the cause, you will never alleviate the symptoms long-term. You may alleviate them short-term, but they will come back. So a hands-on approach is key, but differential diagnosis of your physical therapist is so much more important. Strengthening, low-impact activities, stretching, and modalities will all be used in physical therapy. So our next poll question is, I feel like I have the knowledge and the tools that I need to recover if I injure my back. So go ahead and fill that out, and we'll move on a little bit as I talk a little bit more about physical therapy and what that looks like. So physical therapy, the components that we have here, personalized care. You should have personalized care for your care. So one-on-one benefits with your physical therapist. So it's not a one-size-fits-all approach. You may be having the same symptoms as your neighbor, as your friend, for totally different reasons, right? So an arthritic condition, which is also called spondylosis, can manifest many different ways. So we want to make sure that we're looking at why you're getting this pain. Physical therapy should be decreasing your pain, should be restoring your mobility. It should eliminate potentially that risk of falls or your instability because of weakness in your lower extremity. And our hopes are that we reduce the risk of potential further injuries or the need for surgery. Now, obviously, we know that there are times that surgery is needed, but we really want to make sure that we're working towards avoiding any invasive procedures if we don't have to have them. So we want you to really make sure that you are reaching your peak. So everybody that has low back pain, hopefully you have a little bit of knowledge at this point in regards to what that looks like. So what I look in from this presentation and what you guys said, 55% of you feel like you have the knowledge and the tools. So of 85% of you on this call, only half of you feel like you have the tools. So that is why, and you are the ones that are taking a proactive approach to really make sure that you're getting to what you need to be able to handle your low back pain. So if you have any questions, please don't hesitate to reach out to any one of our clinics. We're happy to answer, we're happy to answer any of the questions that you may have at any one of our 4 locations in Okemos, West Lansing, DeWitt, or Mason. Even if you have what you consider a simple question, one of our therapists would be happy to answer that. It's better to be proactive than to live with low back pain. So I will transition to the last, which looks like the last poll question, and that is, I have had back surgery or consulted with a back surgeon. So as we transition to that, my hopes are that you have the knowledge to be able to avoid that. But like I said, there are times that are needed and you need to find a phenomenal surgeon, which what we have today with Clay Dorenkamp. So Dr. Dorenkamp is renowned doctor, phenomenal surgeon, and we're extremely blessed to have him with us today.
Excellent information, Jill. Thank you so much. And one quick question that I think people would like to know is, we have people who are joining us who put in the comments that they are joining us from outside of Michigan. If they're outside of Michigan, how do they find a good PT?
Yeah, so with your outside of Michigan, you're wanting to look for an orthopedic manual physical therapist. They tend to be trained. So I taught at Oakland University, and so we had therapists that came from all over the world to go through the program. They're called OMPTs, or manually trained therapists that have an understanding of differential diagnosis. So you want to make sure you're just not going into a regular physical therapist, because with low back pain, it's imperative that you're treating the cause and not your symptoms, not just the symptoms.
Very good. All right. Well, thank you. And we will have you back on the screen when we do the question and answer period at the end.
Thank you.
Yeah. So now I would like to introduce Dr. Clay Dorenkamp. So Dr. Dorenkamp is compassionate about providing patient-driven and patient-specific care. It's Dr. Dorenkamp's philosophy that motion is one of the keys to living a healthy life. This has directed him to devoting his career in medicine to orthopedic surgery with a focus on spine surgery. Fundamentally, orthopedics is centered around improving mobility in patients through treating musculoskeletal pathology. Dr. Dorenkamp furthers this by expanding his practice to spinal pathology. In his spine fellowship, Dr. Dorenkamp has trained extensively in both cervical and lumbar spine decompression, spinal fusion, and trained with national leaders in motion preservation, total disc replacements. I didn't even know you could do that. He works with his patients to collaboratively address their pathology through both conservative and operative interventions. Welcome Dr. Dorenkamp to the screen.
Well, thank you, Karen.
Yeah, welcome. And I am looking forward to your portion of the presentation. Although I have to say, I hope I never have to come see you. So I'll let you go ahead and get started.
Thank you. So first off, I want to say thank you to AARP and Karen and her colleagues, as well as Jill, for inviting me to do this presentation. This is something that I'm very passionate about, and really I do this to take care of patients. Nothing makes me happier than to see somebody who struggled with spinal pathology come to my clinic after a really tough surgery and really feel better. So I work at Michigan Orthopedic Center here in Lansing, Michigan, and I really wanted to give you a presentation about understanding spine surgery. I find that a lot of my patients that come into clinic typically don't necessarily understand exactly what the spine surgeon can offer them. And so I wanted to take this opportunity to kind of go through some of the different types of spine surgeries and the different pathologies we typically treat on a day-to-day basis. So I want to start out with my disclosures. I do participate in clinical research for spinal cord stimulation or neuromodulation through Boston Scientific, but otherwise have no other relevant disclosures for this talk. So my background, I grew up in Colorado. I went to Colorado State University where I got my bachelor's degree. I went off to Phoenix to Midwestern University, the Arizona College of Osteopathic Medicine. Then I found my way all the way to Lansing, Michigan, where I completed my orthopedic surgery residency and actually fell in love with Michigan. I'm one of the odd people that actually left Colorado. So, and then I went back to Colorado, anticipating that I would stay in Colorado, but I did my fellowship at the Center for Spine Orthopedics in Thornton, Colorado, or Denver. And then I actually ended up getting a job back here in Lansing, Michigan, where my wife and I moved back to start our careers here. We started in 2021. So my philosophy, I think we alluded to that a little bit in the bio that Karen gave, but the reason I do what I do is I believe that life is motion. I want people to live a really healthy, active lifestyle. And really, my background, growing up, my dad is a chiropractor. So I got introduced to spine pathology and the limitations of back pain at a really young age. That led my interest into medicine, where I went to osteopathic medical school, where we spend a tremendous amount of time focusing on spinal pathology and musculoskeletal pathology in general, learning some of the very same techniques Jill was talking about in her presentation. From there, I had learned that I wanted to do orthopedic surgery, and made my way here to Lansing, Michigan, and then fell in love with spine surgery. That took me all the way to Colorado, where I further developed those skills. And through this, I've been able to really start to see how big of a limitation that spine pathology has on people and what we really can do to keep people going and really get people back to enjoying their life. So one of the first things I wanted to start with is understanding my MRI. I have a lot of patients that I have a lot of my patients that come in with their MRI report in hand, and they have bulging discs and herniated discs and slip discs and arthritis and annular tears and all of these big words on their MRI reads. But people forget that we treat people, not imaging. So I do want to remind people that we've done a lot of studies on people that have spinal imaging that actually have zero symptoms. We found that a third of people that have zero pain in their back or zero pain down their legs have substantial findings on their MRI. If you're 60 years and younger, about 20% of people had herniated discs and didn't know it. And 60 years old and older, 57% were abnormal. And this number just goes up and up and up as you get older. So it's really important to interpret your MRI scans with caution because, like I said before, I treat patients and not MRIs. And it's really important to just not get focused in on what's wrong with your MRI, but really correlating it to your symptoms, which again goes back to what Jill was talking about, that it really takes it's almost an art form for people to learn how to take these MRI findings and the physical exam findings into account to see what best treats their patients. So when we're looking at our lumbar MRI, and I know Jill did a wonderful job going over the anatomy, and I want to just point out what this actually translates to and what I look at on a day-to-day basis. So if you look at the almost center of the screen, the darker gray is your vertebral body. That's the bone or the anterior strut of your spinal canal. It's what holds you upright. The darker spots in the middle are your intervertebral discs. If you look down at the very bottom where you see one intervertebral disc that has almost a white gray appearance to it, that's a very normal looking disc. When you go directly above that one, you're looking at a disc that has some degenerative signs where it's getting black and it's essentially losing some of the water content in it and becoming unhappy. And then if you look more towards the right of the screen, you see that bright white appearance in the middle, and that's your spinal canal. And then you see the structure labeled the cauda equina, which is your spinal nerves traversing through the spinal canal. And then you have the structures on the backside are called your lamina and spinous process, which ultimately make up the roof of the spinal canal. And on the next slide, we look that this is what we would call an axial MRI. It's essentially taking a cross section of your MRI and looking at you from the feet up. So if you look in the very middle of the screen, you see the intervertebral disc or the vertebral body. It's hard to tell exactly what that is based on the axial MRI. Directly to the side of that, on the left and the right, you see those big gray circles, which are the psoas muscles. And then if you look behind what's labeled as the intervertebral disc, that's again your spinal canal. And the little dots inside there are your spinal nerves. And then behind that is the lamina and the facet joints, which make up what I like to call the roof of the spinal canal. This is a picture of a really healthy looking disc space. So moving on, when we look at different pathologies, like Jill talked about, lumbar disc herniations are ones you hear a lot about. So this admittedly is an extreme example of a lumbar disc herniation. The vast majority of these do not get to this magnitude, but you can see where the disc at what we would label as the lumbar 4 vertebra and the lumbar 5 vertebra, or L4-5 disc, has extruded out into the spinal canal, essentially occluding all of the spinal nerves. So the good news about disc herniations, and maybe not ones to this magnitude, is that the vast majority of these can actually be treated without surgery. They've done lots of studies in the past looking at, do you do surgeries? Do people do better with surgery or without surgery? And really the conclusion of that study was, well, everyone does about the same between like the 3 and 5 year mark. It's whether you can tolerate your symptoms long enough to get to that long period. That, of course, is in the absence of any significant neurologic deficits, such as changes in your bowel or bladder, or pain, or specifically like progressive weakness in your legs. Things that are very helpful that help you avoid surgery are doing exactly what Jill was talking about before this, physical therapy. You can even talk to your doctor about epidural steroid injections or transforaminal epidural steroid injections, all just variations of where they inject steroid around the herniated disc to help decrease some of the inflammation around the nerves. Moving on to the next slide, we talk about, well, what if we do cross that bridge where we have really tried all of the conservative care and really need this surgery to fix this? Well, when we're talking about in the terms of spine surgery, this is a fairly minimally invasive surgery that we do quite often, actually. And this is when you're talking about a microdiscectomy or a laminotomy. Those are both very similar words, meaning that we take off a small amount of bone. We don't take down any of the joints or anything that destabilizes the spine. And it really gives us access into the spinal canal where we can essentially reach in, move the nerves over to the side, and remove the disc herniation. Now, anytime you do surgery on the back, you're damaging those little muscles, the multifidus muscles and the erector spinae that Jill taught us were so important. That's why I like to really tend to avoid spine surgery unless patients can fail fairly extensive conservative care. Typically, when you're talking about this surgery, this is most of the time an outpatient surgery. It usually takes between 1 to 3 hours to do this surgery, depending on the extent of the pathology. And typical recovery time for this is about 6 weeks. And I tell people to avoid any bending, twisting, lifting for that time, because we really want to let the structures in the spine heal and scar down so we don't get any recurrent herniations. Moving on to the next pathology that we see a lot is lumbar spinal stenosis. And this is where, if you remember back to where Jill was talking about, you get degenerative discs and you get arthritis in your back. The arthritis tends to create the facet joints or the small joints in the low back to grow and eventually compress the spinal nerves. There's also a structure, if you look in the L4-5 picture, which is the one that has the most pathology compared to the L3-4 picture, you can see that there's a really dark black line in the facet joints, and that's a ligament in your back called the ligamentum flavum. And we know when you get a lot of arthritis in your back, that particular ligament gets really thick, which can cause the spinal stenosis. Now, for spinal stenosis that doesn't have any instability, you'll see on the next slide, the typical surgery we can do that is called a laminectomy. So the laminectomy is a surgery where we go and we remove the roof of the spinal canal and take the pressure off of the spinal nerves. So the other important thing to talk about with spinal stenosis is, what are we actually treating and what are the goals of treatment with this surgery? Well, spinal stenosis is kind of a unique pathology, is that when those nerve roots get compressed, they don't always cause pain. A lot of times they'll just cause the legs to feel very fatigued and feel almost like they have lead weights after you walk a certain amount of distance. And it's usually a very similar distance every time you walk that you notice your legs get really heavy, and you either have to sit down or stop for a minute. A lot of people that have spinal stenosis will also notice if they use a shopping cart or some type of assisting device where they can bend at the waist and kind of flex their spine down, this opens up the space and their legs will feel better. This can also cause back pain because of the arthritis in the facet joints. When there's no instability, we're able to just decompress the nerves and not do any fusion procedures. When we move on to the next type of pathology, this is when arthritis in the low back gets really bad and you have a spondylolisthesis. This is a big fancy word that means that one of the vertebrae has slipped forward on the other. And this particular type of spondylolisthesis is called a degenerative spondylolisthesis, aka it's caused by arthritis and the joints in the low back becoming incompetent and unable to keep healthy alignment of the spine. When this happens, we see a very similar pathology in that the spinal canal gets shrunk. You typically have a little bit or quite a bit more back pain in this scenario. And again, you have that symptom in your legs that you feel like there's a lead weight and you feel like your legs get very heavy when you walk a certain distance. So, and interestingly, when you have this pathology, about 10% of the people in the population that have this also have this in their necks and can cause something called cervical myelopathy, which can cause your hands to be clumsy, drop things, and your balance to be really poor. So it's always something to consider if you're starting to see some of those symptoms and you know you have back problems. It may also be worth having your neck checked out. So when we get to spondylolisthesis, we know that this is the result of an unstable spine. So when we talk about treatments, there's a whole multitude of treatments that we undergo to treat this specific pathology. So on the next slide, we talk about what we'd call an anterior lumbar interbody fusion or an ALIF procedure. This is a surgery where we actually approach the spine from the front through your abdomen. This is done in combination with a vascular surgeon because we have them exploit a very natural plane in your abdomen, which allows us to avoid injuring all those small muscles in your low back, aka the multifidus and erector spinae that Jill was talking about, and gives us direct access to the disc. We have the vascular surgeon help us because it requires us to mobilize and move some of the great vessels out of the way. So we do that as a team to make sure we do this very safely. That allows us to take out the disc and put a large implant that's filled with bone graft in it, as well as screws into the front of the spinal canal or the vertebral bodies to help stabilize that spinal segment. And this can actually decompress the nerves indirectly by creating more space and restoring the height of that degenerative disc. So on the next slide, we talk about another type of spine fusion. This spine fusion is called a TLIF, or transforaminal lumbar interbody fusion. A TLIF procedure, we actually put the cage and bone graft in from the back, and we take off part of the lamina and allows us access to the disc space and allows us to fuse the spine that way. Both of these procedures, the TLIF specifically, require that you put in pedicle screw instrumentation, which you see on the next slide, that we use these natural corridors or these bony connections between the vertebral body and the back of the spinal canal to put these really strong titanium screws in the back to help stabilize these. These are mandatory when you do a TLIF procedure, but can be optional when you do a ALIF procedure. Now, there are other possibilities for fusion. There is lateral fusions and oblique lateral fusions. Ultimately, all of them have the same goal, is to recreate the alignment and the disc height and promote bony fusion. Pedicle screws are probably the most common type of fusion procedure and can be done in combination or without the interbody spacer itself. So that's not always a necessary step depending on the specific pathology. When I'm talking about people with specifically low back pain, I tend to prefer doing a strictly anterior, or the surgery where we go through the abdomen to avoid damage to the muscles. If we're talking about more of a compressive pathology, I tend to go and use more of a posterior or surgery where we only go through the back and spare the abdomen. But there's a lot of different combinations that we use to treat various areas of compression of nerves. Next slide, please. So lastly, this is what I would like to call an emerging technology. However, it's been present for approximately since the 1990s, but it's really gained momentum and had a lot of advances in the last 5 or 10 years. And that's neuromodulation. Neuromodulation is a electrode that we implant surgically onto the thoracic spinal cord with the goal of it sending these really complex electrical signals to the back of the spinal cord, which controls the sensation in your body and helps shut some of those nerves off. This can be very successful in patients that have chronic low back pain or even patients that have failed spine surgery. It's good for treating specifically low back pain and even radicular pain or CRPS pain, or the complex regional pain syndrome. And next slide, please. So kind of the discussion that I would like to start is, when is spine surgery right for me? And when we're talking about the low back, spine surgery is only right for a person when they've reached a point where they've failed all of the conservative therapy and it is altering their quality of life. I always tell my patients that spine surgery is never mandatory. Now, in circumstances where there's neurologic deficits, or you're having these problems in your bowel and bladder and balance issues, these may become more urgent issues. But for the most part, most of the time, spine surgery for radicular pain or low back pain is only when you deem it necessary. The other thing to talk about is, will spine surgery take away all my pain? And unfortunately, the answer to that is probably not. Our goal as spine surgeons, and while we always hope that it takes away all of your pain, my ultimate goal is to stabilize your spine, prevent any further neurologic injuries, and ultimately reduce your pain where you can have a good quality of life. And then lastly, we always hear about spine surgery. If you have spine surgery, you're going to need more spine surgery. Unfortunately, that is also a risk factor of spine surgery. Anywhere between 10 or 15 patients that have a fusion of their lumbar spine will need a fusion at another level. Similarly, if you have a fusion of your neck, anywhere between 20 to 30% of people who have one level fused to their neck will need another neck surgery within 10 years. But I also relate it to that when we go to the dentist, if you get a cavity in one tooth, it doesn't mean that you can't get cavities in other teeth. And we have to realize that the spine is made up of an extremely large number of small joints and has really complex biomechanics that can all go bad independently. So with that, I want to say thank you. I enjoyed talking to you, and I look forward to answering your questions.
All right. Thank you so much. Interesting, a little bit scary as someone who has both neck issues and low back issues. I really hope surgery is not in my future. We have quite a lot of questions, but I want the poll results were that we asked just before you came on, Dr. Dorenkamp, that 24% of our viewers have already consulted with a surgeon or have had surgery. So that's interesting. All right. So Debbie asks how you referred to, this is for Dr. Dorenkamp, how can spine issues affect your bladder?
Oh, that's a really interesting question. So your bladder is a very complex organ, and it takes a lot of nerves that travel right through the cauda equina or your low back to send the correct signals to that to allow it to hold urine and both expel urine. One of the more common things that we look for with urinary issues is urinary retention, people unable to void. That would be a concerning finding for me as a spine surgeon.
Okay, interesting.
We also look at that from a pressure standpoint, and because your bladder is so close to your pelvic floor, you have your pelvic floor, which your bladder is kind of the sling for your bladder. You have your diaphragm on top, you have your abdominal muscles on the front, and your spinal stabilizers on the back. So you think of all four of those pressures. I'm actually certified in pelvic floor therapy as well. And so we work from an internal standpoint to assist in making sure that you have appropriate pressures, because if your pressures are off, it significantly can increase your back pain, as well as cause increased bladder leakage and abnormal pressures. So you can have urgencies, you can have, bladder retention, as well as the nerves, innervated by S2, 3, that affect your bladder and your specific bladder reflexes that are stimulated from your spine. So multi-organ levels that we look at in physical therapy as well.
Mm-hmm.
All right. Well, it just doesn't seem fair that all this can happen just by getting older. So Anna asked, how much does osteoporosis factor into back pain, and to what extent can osteopathic patients be treated with back surgery?
Yeah, so that is a great question. Osteoporosis is something I look at every day in my patients. Osteoporosis plays a major role in back pain. A lot of patients that have severe osteoporosis are at high risk for vertebral compression fractures, are fractures in your back that can happen from very, very minimal trauma to your back, sitting down in a chair too hard, hitting a bump in your car, and that can cause extreme low back pain. And anytime the bones are weak and change their biomechanics, that definitely contributes to more low back pain. The other aspect of osteoporosis that I really take into consideration is when we're talking about surgery, specifically fusion surgeries with osteoporosis, because it makes the risk of surgery go way up and the risk of the hardware coming out or failing to fuse the bones. So I always advocate that patients go to their primary care doctor and really get ahead of their osteoporosis, because it can have very detrimental effects on you later in your life.
All right. And that's not good either. That's part of just aging also. So this one's for Jill. Jill, what is, so you talk about prevention of disc issues, and so strength training and flexibility and non impact aerobic activity, is what you said. Is that correct?
Yeah, so, I think Jean has asked too, like, what is the best flexibility exercises? And oftentimes when people think about low back pain, they oftentimes think that you just need to be strong. You need to be strong. Well, I have a lot of professional athletes that I work on. I have a lot of, individuals that are very strong that still have tremendous amount of back pain because they don't have the flexibility. So you saw in Dr. Dorenkamp, those big muscles that he called the psoas muscles, those are the hip flexor muscles. And so those attach directly to the front of your back, and maintaining good flexibility of your quadricep muscles that are on the front of your thigh, your hamstring muscles that are on the back that both attach to your pelvis, your hip flexors, your iliopsoas or your psoas major, which are two muscles that they flex your hip and they attach to your pelvis and the front of your lumbar spine. So some of the best flexibility exercises are to make sure that your lower extremity muscles, where they attach to your spine, are long enough. So stretching to your quadriceps, stretching to your hamstrings, stretching to your hip flexors, your iliopsoas or your psoas major, are ones that really help your spine, even though they're not directly attached to them. But every time you walk, will cause that transitioning or that pistoning through your lumbar spine if they are too tight. Now, you also want to make sure some of those good flexibility muscles of your rector spinae muscles, your multifidus, some of those little small ones, your semispinalis muscles, that they're flexible but strong in your back as well.
So I want to echo exactly what Jill just said. I talk to patients every day that come into my clinic with low back pain. And when I suggest physical therapy, they're like, well, like, I have a really active job. I lift stuff. I'm really strong. I don't need physical therapy. And I always stop them. I say, well, I know, but we got to work on your flexibility and really strengthening all of those specific muscles to work in coordination with each other, because they're working out of balance and the biomechanics is off, which is causing some of your back pain. So I think it's really important to emphasize that even if you're a big, strong, laboring adult, like even that can have great benefit with physical therapy.
Well, I appreciate that you aren't just let's just slice and dice them then. Yeah, that's so Charlotte asks, what happens when you don't take care of a bulge disc? So is that for sure? What's the progression if you don't take care of a bulge disc?
So I would say that if we remember back to one of my first slides, when we talk about understanding your MRI, almost everybody, as they get into their 60s, 70s, 80s, etc., are going to have a bulge disc, if not more than one, if not a lot of them. Ultimately, bulge discs in isolation are nothing to worry about. I see that every day on almost every single MRI I read. I think the biggest thing to do for your bulge discs is really make sure you're maintaining a healthy weight. You're doing that anti-inflammatory diet, which more and more research continues to come out to show how big of a deal that is. And really keeping your flexibility and your core and low back muscles strong to help stabilize that spine and that bulge disc. Because really a bulge disc is just, as we get older, as we lose water in our discs, as Jill had said previously, we kind of lose how there's structure a little bit, and the bulge is like the radial tire just kind of bulging out as it gets a little bit older. Yep.
And I would say that a bulging disc is also a sign of a little bit of instability in your back. So, I would take it as an indicator that you do need to do something, because if your ligaments start to stretch out, then you need to make sure, because what stabilizes your back is your discs. And then you have, your ligamentous tissue that's in through there, your muscles in that area. So if one of them starts to go, if your disc starts to go or starts to be degenerative or bulging, you need to make sure that your muscles then are countering that effect so that you don't get the slippage, because it's the slippage and the touching of the nerve when you start to get the pain. Because like Dr. Dorenkamp said, you can have a bulging disc and be totally asymptomatic. But it's when it starts to touch nervous tissue that actually give you symptoms is when you then start to develop the low back pain and the referred pain and that kind of thing. So you can have a bulge disc all day long, but when it starts touching nerve structures or you start to get the instability there is when you really start to get into problems. So knowing that you have it, increasing your strength, making sure that that slippage is controlled is something to be really preventative in regards to long-term, or you'll have a better prognosis if you address it that way.
Yep, I agree, Jill. And one thing that I see in some of my patients, and this is not a completely scientific term, but I see a lot of people that have bulge discs or like collapsed discs that I call them back comas, where something really insignificant, like you bend over to pick up a pencil, your kid jerks on your arm a little bit too hard, and it'll completely set off all of this spasm in your low back, and it almost can be incapacitating for a couple days. And I think going exactly back to your point, that's caused by micro instability in the lumbar spine, where you have some of those disc bulges that allow just this little bit of translation, even though it may be imperceptible on x-rays or MRIs, but it's enough to set off this huge chain reaction in your back. And again, that's where, it's really important to keep your core and your low back muscles strong.
Okay. We have time for one more question. We've gone over a little bit, but we've had a lot of good questions. So Linda asked if you will discuss the sacroiliac joint issues. You didn't talk about that at all. I know Jill and I have had lots of conversations about this one. So,
yeah.
What can be done? I know there's things that can be done from the physical therapy standpoint, and I'm sure there's things that can be done by the surgical standpoint. For Jill, you want to talk about the physical therapy standpoint first?
Yeah, so from the SI joint, and I would tell you that, obviously your SI joint and what it is your sacrum. So your sacrum is the base of your spine, and your sacrum is fused vertebra that make up a triangle, and then your coccyx is at the bottom. And so your sacrum, where it attaches into your pelvis, is your SI or your sacroiliac joint. And so oftentimes what can happen is you can have rotations, and what happens is it looks like this. And so as you load, your sacrum moves forward and seats down into your pelvis. So as you stand, your pelvis kind of moves back and your sacrum seats down into your pelvis. So your pelvis rolls backwards and your sacrum rolls forward and it locks in. Now, a lot of times people come in and they say that your sacrum, like, oh, my SI joint is so stiff. Well, I got news for you guys. Like, it's supposed to be stiff. It is supposed to stabilize. It's supposed to be the platform for your spine to stay on, right? So you don't want a mobile platform. You want something that is nice and stable. Now, oftentimes we'll see with pregnancy or different things like that, hormones, because there's not a lot of muscular attachments directly that stabilize it. A lot of fascial attachments go across there and ligamentous tissue, sacrotuberous ligaments, and some broad structures that go across there. But it is supposed to be a structure that is highly stable. Now, oftentimes with increased changes in women and hormones, or car accidents you'll see, or somebody where you're like fall off a step where you have a shear, you can get a shear to where your sacrum is sheared up or your pelvis is sheared back, or you get some rotations through that joint. They can be extremely painful. And some differential diagnosis of that is pain in unilateral standing, so pain going up and down stairs, any kind of alternating where staggered stance would be really painful. So you will know if you have an SI dysfunction, and typically it's due to trauma or ligamentous instability. Now you'll have some, if you have some hypermobility or increased motion, you'll have some changes in your sacrum. But if your SI joint and your sacrum is moving, it can highly affect your L5, S1 vertebra, because S1 is the top of your sacrum. So it's really important that you maintain that nice, stable pelvic sacrum structure so that your spine can move accordingly on top of it.
I think that was a great explanation. So from a surgical perspective, the SI joint is really tough to treat surgically. There are fusion procedures that we can do. I tend to try and avoid doing those if I can, because, like I said before, it's one of those surgeries that doesn't necessarily take away all of the pain, but it can decrease the pain. Also, kind of going back on what Joe was talking about, we have to realize that a lot of the muscles coming from the low back form this lumbar aponeurosis that attaches kind of in that same area as your SI joint. And I think a lot of people confuse this low back pain associated to muscular issues to SI pain, where you have this inflammation kind of overlying that general area. The other thing that can be helpful is there's pain doctors that will do injections in the SI joint, which is actually one of the diagnostic tests that we use if we're considering a fusion, is to get an injection into that joint and see how you respond to it.
Very good. Well, I want to thank both of you for all of your information, taking the time out today to join us on here and sharing your knowledge. And I will tell our audience, thank you so much. And you can, if you want to rewatch this, it'll be available on demand immediately after. And you can also find it at a later date if you want on our aarpmichigan.org or aarp.org/mi website, and click on virtual events and you can find it there. So thanks so much. We appreciate it. And I am sure that there are probably many people out there who are thinking, great, I don't have to have surgery. So have a wonderful evening, everybody.
Thank you so much. And thank you, Karen and AARP. You guys do a fabulous job of putting out these wonderful educations so that people have the tools and the knowledge to really get better.
Yep. Thank you.